These are absolutely some of the toughest cases that you'll encounter, and this is a patient who has diabetic tractional detachment with vitreomacular traction and a very adherent mid-peripheral vitreous and vitreous schisis. So I start out doing a core vitrectomy. I'm not having much success elevating the posterior hyaloid, so I go to a high magnified view. And now I'm using my max grip forceps to try and elevate the vitreous off of the optic nerve. Now I usually find that this will create a really nice PVD if you can get this fibrotic tissue off the nerve. And I peel it out into this kind of mid-peripheral inferotemporal fibrotic plaque. Now the main reason this patient was being taken to the OR was because of progressive traction in the macula. And realistically, I think if I'd gone back and analyzed the OCT a little bit more, I would have realized that the hyaloid was still very adherent to the macula. Even though it looks like I'm obtaining a posterior vitreous separation here, and I'm having some modest success in the mid-periphery, it's just not coming up the way I would want it to come up. Here I'm trying to drag and aspirate with my cutter, and I really like using the cutter to try and obtain a vitreous separation here. But I'm just not having much success, and this should be a tip that I had vitreous schisis and did not have a good PVD, because this vitreous just would not come up with my cutter or even with the fluidics. So I stain a little bit more with ICG just to see if maybe I can peel the ILM, and lo and behold, after staining with the ICG, I find that this patient still has very adherent posterior hyaloid over the macular area, and you can kind of see it bouncing around in the classic sheen. So under high magnification and with the aforementioned max grip forceps, I'm able to actually pinch and peel and create an opening in that posterior hyaloid, and then that gives me a really nice chance to get in there and grab and just peel up that posterior hyaloid. Now I go to a more wide angle view so I can deal with some of the mid-peripheral traction, and I find that the going is much easier now. I'm able to elevate things with my vitreous cutter a little easier, including this fibrotic plaque that's down in this area of laser, watching carefully both under my cutter and distal to make sure that I'm not exerting any traction on the retina. But look at how much easier this comes up now. And I'm able to very rapidly remove that fibrotic traction and achieve really a total posterior vitreous separation so that we don't have any more peripheral traction that could result in hemorrhaging. Watch how much easier this temporal plaque comes up, and I'm able to just really easily remove this from the surface of the retina with the high-speed 10,000 cut per minute beveled cutter, getting right down on top of this fibrotic area and just basically eliminating it. And then I go all the way around to make sure I have the vitreous elevated 360 degrees so I don't leave any areas peripherally still tacked down. Fill in with some additional PRP laser, and then I always like to leave these patients, if possible, under air or gas to avoid any recurrent hemorrhaging. Thanks so much for watching.